Hello there, this is Dr. Ali. I'm Dr. Ali, and welcome to today's talk. I'm just going to share my screen, which is going to be here. And then I'm going to slideshow, present the view. There we go. So welcome to today's webinar masterclass. It's great to have you here, and I'm so glad you are, because the gems that I'm going to share with you today may save your health, may even save your life or that of somebody close to you. So I can't stress enough how important this information that I'm going to share with you today is. So today we're going to go through some of the secrets that are hidden away in your blood tests, and also how to get hold of some of the extra tests that your doctor may not be able to order for you. So there's all my initials. So I would just wonder, do you know anybody with cancer, arthritis, diabetes, chronic lung disease, heart disease, stroke, dementia, prostate problems, or Parkinson's? The chances are that you do. Obviously, as a doctor, I know people with all of these, but also with my own relatives. I've seen people get this, and not necessarily at an older age. And what I'd like to share with you today is to show you some of the ways where these things can be picked up early and the progression towards them even be delayed or prevented. There's a lot we can do for our health if we are proactive, but we can't just rely on traditional health systems to help us with that. Let's take heart disease, for example. Did you know that one person dies every 36 seconds in the United States alone from cardiovascular disease? That means about 655,000 Americans each year, 40% of all deaths. Did you know that women under 50 are twice as likely as men of the same age to die from a heart attack? We used to think that heart disease mostly affected men, but it's now recognized as a leading cause of death for women. In fact, while men are more likely than women to experience a heart attack, and at younger ages, women who do have heart attacks are more likely to die from them. And women catch up rapidly after the menopause. Half of heart attack deaths occur within an hour of the event. Half. That doesn't give you any time to get to hospital. And the cost of heart attacks is over $60 billion in medications, hospitalization, and not to mention loss of work, loss of quality of life. Did you know that with the right kind of testing, we can predict your risk of heart attack and prevent many, if not most, of these deaths? I've experienced these statistics firsthand myself. I've seen it in family, friends, and patients. My husband's best friend had a heart attack at the age of 52, only 52. He was in a coma, but never regained consciousness and died a couple of days later. That was in April 2020, so right at the beginning of lockdown. There was nothing we could do. We couldn't visit or anything. I remember my shock as a doctor when a 42-year-old female patient I knew well succumbed at 42. No obvious predisposing factors. They didn't know they were at risk. I didn't know they were at risk. Neither was diagnosed, nor were they on medications. They just died suddenly, leaving their families and friends devastated, as you can imagine. And both were under the age of 65, the age when people start to think about such things. Tragic deaths that could have been prevented with the right testing, followed by the right nutrition and lifestyle interventions. And I was even unable to help my own patient because this was the NHS. No time, no system to go deep as I do in my functional medicine practice. And as for diabetes, did you know that even though, according to the CDC, diabetes is considered the 7th leading cause of death in the US, blood sugar dysregulation is likely to be the true leading cause of death? According to the CDC, diabetes may be, that's the Centers for Disease Control in America, diabetes may be underreported as a cause of death. And I can confirm this as a doctor who signs death certificates. We may often forget to put diabetes as a contributing factor or not even feel that it is. So we may put heart disease down and not put diabetes down. And we would certainly not put glucose dysregulation down because that's not a diagnosis. And in allopathic medicine, we're talking in terms of diagnoses. Blood sugar dysregulation or insulin resistance is a leading cause of heart attacks, strokes, vascular dementia, peripheral vascular disease, which is furring up of the arteries. So the heart attacks are furring up of the arteries around the heart that supply oxygen to the heart. Strokes are furring up of the arteries to the brain, so supplying oxygen to the brain. Vascular dementia, likewise, vascular dementia is caused by mini strokes. Peripheral vascular disease, which is caused by furring up of the arteries to the legs. And because these have one root pathology, as you can hear. In fact, it's estimated that 50% of all sudden cardiac deaths are due to insulin resistance as a primary underlying cause. I have my own story to tell here. I remember vividly one of my aunts being blind because of diabetes. When we visited them on the Isle of Wight when I was very young, I was probably about 5, I can recall easily the smell of formalin in her kitchen because smells stay in your memory. Because there were no disposable syringes in those days. Little was known about diabetes. She had to sterilize and reuse both glass syringes and metal needles in a big pot on her Aga. I'm just going to let the dog out. Come on then, Stepson. Sorry for that intervention. Ava's going to stay with me. She's the Labrador, but So's a retired foxhound and a little bit less predictable, shall we say. So I can remember her having to reuse those syringes and needles. And she became blind soon after that. And she died when I was still quite young, maybe 9 or 10. Tragedy for my mum. My brother was diagnosed with type 1 or autoimmune diabetes when he was 7. It was a tragedy for him and heartbreaking for my mum. He was bullied mercilessly at boarding school because of the need for the syringes, at least disposable by then, so at least he didn't have to boil glass ones by then. And then his life was changed by the appearance of the first Novo pen. It was a pen-like device that looks cool and has both the insulin and the needle hidden in it. Suddenly he became cool because of his diabetes for the first time, but he was still affected mentally by this situation. My closest aunt, Auntie Beryl, then went on to develop type 2 or maturity onset diabetes, probably in her late 40s. She lived with my mum for 18 months. It was supposed to be a long-term arrangement. They were going to be doing bed and breakfast for decades, but she developed multiple organ failure, again, because of diabetes. My mum then developed type 2 diabetes. Of course she did, in her 50s. She went on to develop, in turn, peripheral vascular disease due to blocked arteries in her legs, ischemic heart disease due to blocked coronary arteries in her heart, with heart attacks and open heart surgery because she had a valve problem, and then vascular dementia, as I said earlier, caused by mini strokes and furring up of the arteries to the brain, all secondary to diabetes and blood sugar dysregulation. Today, you will learn a little about why and how this happened and how it can be stopped in its tracks and how you can prevent this happening to you, how I'm preventing it from happening to me. This was my mum earlier in 2023. Because of the diabetes, she developed vascular dementia as well as heart disease and peripheral vascular disease. She was in a series of nursing homes and very happy there, but they never understood an optimal diabetes supporting diet. They still gave her sandwiches with white bread. They still gave her jelly and ice cream, just like the hospital did. It's atrocious when you know a little bit about what spikes blood sugar. She had a headache one day and was put on prednisolone, a steroid, for 2 years, just in case it was temporal arteritis. Now, as doctors, we have to be very careful about temporal arteritis. It can cause blindness. It was never shown to be that. And as a result of her diabetes, her diabetes was much worse, more difficult to control, and that in turn made the dementia worse. We were lucky. She still recognized us until the end and was very happy in the nursing home. She had people around her, activities, and although she was unable to walk, they hoisted her to move her, which she loved, as it was like being a small girl in a swing again. As you can see, she still retained her love of life, her ability to laugh, and her patience with people. Mum died in June of last year, but she could have been mentally and physically fitter for much longer. And if I lived like she did, she was an excellent cook and made the best cheese scones. I used to as well, but I don't bake because I know how bad the baking is for our health. Then I would be diabetic too. And I believe that no one should die of type 2 diabetes, and very few from type 1, if proper testing and lifestyle intervention is performed. But that's not the way allopathic medicine works. In medicine, we're afraid to upset people by insisting that they change their lifestyle, not understanding the power of proper advanced cellular supplementation. We don't understand the importance of herbs and lifestyle change. We're committed in allopathic medicine to propping up the country's taxation income by continuing to rely on pharmaceuticals that in fact poison the earth and the humans they intend to heal. So, what are the correct tests that should be run to detect and prevent diabetes and heart disease death before it gets serious? That's what we're here today to review. What most people don't know, and what most doctors don't understand, and certainly underestimate, is that there are hidden clues in your blood, often decades before you develop symptoms, that warn you about the danger of heart disease, diabetes, cancer, dementia, and more. Who'd like to hear more? I've been a deep thinker and a detective of sorts since birth. I was always out on the farm, connected to nature, wondering what made things tick. I was all set to go to medical school when in the summer of 1985, my ex-boyfriend, that boy racer, he was 18, rolled his car. He was racing another car on a twisty road and the car rolled. It stopped near the edge of the cliffs at Beachy Head, a well-known suicide spot. And they were cut and bleeding, so I got out of the car, picked up the things that had been dropped, flotsam and jetsam, my motorbike helmet and my road atlas. But when we got to the hospital, thanks to a passerby, I was waiting for my mum, and I couldn't sit any longer in the waiting room. They assumed I was fine. The other two were bleeding, so they were taken off to be assessed. But I was lying on the floor of the reception area. Thanks to a very alert receptionist, she suggested that I get reviewed by the medics, and my back was broken in 2 places. But I was alive and determined still to go to medical school. If only I'd taken a year out, my back would have been better, my health and my mental health would have been better. But I went straight to medical school at the end of that September, so like barely 6 weeks later, imagine. All the time, they were teaching us that medicines and surgery held all the answers to our health. They taught us to stop using our intuition because we're relying on science, not intuition. My back ached constantly, despite the pharmaceuticals, and surgery was not an option. So I learned my own way of holistic medicine, integrative medicine, integrating the best of Western and complementary medicine, and later functional medicine. But I never forgot my roots and my mission to help women and men globally to experience fabulous health, but not at the expense of their planet. I was shocked when I heard that the estrogen from contraception and HRT that we doctors were prescribing was getting into river water and leading to the fish changing sex. Who can remember that? So I started medical school in the 80s. It must have been soon after that or early 90s that this was discovered. But even more shocked when that was the last I heard. There was no call for a change in our prescribing, no call for women to find alternative approaches to contraception. Now, I know, and as a feminist, I'm the first to acknowledge that we have more control over our lives as women because of the contraceptive pill. We are thriving through menopause far better because of hormone replacement therapy, but at the expense of the planet. And now I get to use my skills as a functional medicine doctor, which means we're looking at the grassroots reason for things rather than just sticking a sticking plaster of a treatment onto things. I'm able to use those skills to help tens of thousands of people to understand the imbalances in their bodies that can be reversed so they can lead a healthy and vibrant life and have what I term vibrant health, healthy hormones, healthy organs, healthy brain, healthy being. So are you ready to learn? And more importantly, are you ready to take action to protect your greatest asset, which is your health? I'd like to think for a moment, what's one thing you'd like to walk away with tonight to make the time spent worthwhile? And one final thing to add, what would you be doing with your life if you had truly vibrant health and hormone balance? I know you have other things you can do with your time, and I so appreciate you being here with me today. I'm dedicated to helping you to change our broken medical system. And by being here today, you are voting to help do that. So to get the most out of this training, I do want you to focus. So turn off your cell phone, turn off Facebook, except to invite your friends to attend. Stay focused. Open your mind and heart. I just have to point out this medical disclaimer. In this position, I'm not your doctor. The information in this presentation is not to replace a one-on-one relationship with a qualified healthcare professional. It's not medical advice. It's intended as a sharing of my knowledge and information from my research and experience. And I encourage you to make your own healthcare decisions based upon your research and in partnership with a qualified healthcare professional. This is for informational purposes only. There's no guarantees. So let's start with an explanation of normal versus optimal lab values. Most patients who feel unwell will come out normal on a blood test. Ever had that? I see hundreds of people who go to their doctor because they have tiredness, headaches, exhaustion, bone pains, joint pains, muscle pains. They're not feeling right, but they're told everything's normal and they're made to feel small. In fact, I was talking to my daughter who has chronic pain just yesterday, and she was almost in tears because of this. Really, I call it medical gaslighting, where because we doctors have been taught to stop listening to our intuition, we don't respect patients' intuition. And it's difficult to find somebody who will listen sometimes. So let's look at that. Why is it that they feel unwell, but their blood tests come out normal? That's because most lab ranges are based on the statistics, the average of the people who come in for testing, rather than on whether a certain value represents optimal physiological function. Most normal ranges are too broad to adequately detect health problems before they become pathology and are not useful for detecting the emergence of dysfunction. In fact, that's the whole point. With allopathic medical systems, they don't want to make more people unwell with tighter lab ranges because that would flood the medical system and it wouldn't be able to cope. So we're looking at 95% confidence intervals. So if you look at a whole population bell curve, we're looking at the normal lab ranges are the 95%. So there's only 2.5 below and 2.5% above that are considered abnormal. And that gives us our abnormal levels in allopathic medicine, allopathic meaning the usual Western approach to medicine. These people are by no means normal. If you think about the general population, these people are by no means normal. They're a far cry from being functionally optimal. For the most part, those who get testing done and contribute to that normal range are feeling unwell. They've gone to the doctor for tests because they've got headaches or tiredness, and they've not yet progressed to a known disease state, but they are what we call dysfunctional. So let's look at some definitions. First of all, biochemistry. This is the chemical reactions that go in the body. When we're talking about lab tests for biochemistry, these would be grouped together, all the things generally that aren't hematology or immunology. So we'll come to those in a minute. So biochemistry includes the salts in the blood, so sodium, potassium. It includes blood sugar regulation markers. They include the liver function markers. and several other ones. So that's what we refer to as biochemistry. Thyroid function falls under biochemistry in lab terms as well. Hematology, these are the things pertaining to the red and white blood cells. So biochemistry is generally looking at the serum, which is the part of the blood left behind if you take the cells out of the blood. Hematology is generally looking at the cells. So it's looking at the red blood cells, which carry oxygen around in the blood, and it's looking at the white blood cells, which generally are involved in our immune system. Biomarkers is a word used for these different markers that we are measuring in the blood. And you may use the phrase biomarker for things that are measured in urine or saliva or other things. And then functional medicine, as I've alluded to before, it's grassroots medicine. So instead of saying this person has heartburn, let's treat them with a proton pump inhibitor to reduce the acid so they don't get that symptom anymore. Instead, we're looking at what's causing the sensation of heartburn. Is it actually too low stomach acid? If that's the case, let's look at why they've got too low stomach acid. Do they need some probiotics? Do they need further investigations to look at dysbiosis? Do they need to take some extra hydrochloric acid with their meals to enable them to digest properly? So that's a very different approach. And you can see that there's no time for that in the allopathic medicine approach. Plus, there's not the will for it either because we're not trained in it. And then immunology, these are basically anything related to the immune system. So if you've got an overactive immune system, you may get autoimmunity. So you may get those autoimmune disorders that are so common nowadays: psoriasis, rheumatoid arthritis, type 1 diabetes, vitiligo, autoimmune hypothyroidism, and Graves' disease, which is autoimmune hyperthyroidism. So there's a whole load of them. That's when you've got a hyperactive immune system. And most of those markers are actually fall under the biochemistry markers. And also the immune system, when it's underactive, you may be getting more infections. So we're looking at fighting infections and when it's overactive as well. So with the functional approach to biochemistry and hematology, we're looking at changes in physiology, not pathology. So physiology is how the body works. Pathology is when the body has an illness or a disease. So pathology is when things are going wrong. Okay. So we use ranges in functional medicine that are based on optimal physiology and not the normal population. This results in a tighter functional physiological range, which allows us to evaluate the area within the normal range that indicates that something is not quite right in the physiological systems. So, for example, if we look at the glucose, I'm going to use the standard international units here. The normal minimum and maximum are 3.61 to 6.11. So anything above 6.11, we'd be thinking of pre-diabetes in inverted commas. And likewise with the HbA1c, which I'll explain later, it's looking at the last 3 months of blood sugar. 29 to 41 is how we would interpret normal. But in actual fact, when you look at optimal, you have much tighter range, and anything between 4.94 and 6.11, things are going awry with your blood sugar balancing, with your blood sugar processing. Likewise, if your HbA1c is above 31, things aren't quite as right as you think, or as your doctor thinks. We can identify factors that stop you from feeling fabulous, stop you from having optimal physiological, biochemical, and metabolic functioning in your body. Also, we're not simply looking at one individual biomarker at a time in a linear report of the data. We use trends with the blood chemistry report I'm going to explain to you, I'm going to share with you today. We use trends between the individual biomarkers to find otherwise hidden trends towards or away from optimal health. And with what you learn tonight, you'll realize that blood testing is no longer simply a part of disease or injury management. Let's wait till I'm sick. It's a vital component of a comprehensive functional medicine workup and plays a vital role in uncovering hidden health trends and disease prevention. In short, this will help you to achieve optimal health now and in the future. Here's another example related to the blood sugar that I looked at just now. So here, the brackets show the UK or standard international units. I didn't convert the cholesterol, but ideal would be 3.6 to 4.9. Insulin resistance is 4.9 to 6.11. And then that progresses to metabolic syndrome, 6.11 to 6.99. And then diabetes, we would diagnose at 7. Now, in allopathic medicine, in general practice, in the National Health Service and other such systems, we're only looking for when the HbA1c is above 41. So yes, we would flag this up as abnormal, but there just aren't the resources in the NHS to manage this effectively. You may get sent on a training program, but I've heard from patients that the training program is not good. I expect it varies from place to place, but they're still being advised to eat high glycemic foods. So it's not ideal for preventing this from becoming this. And then here you can see that there are some changes already that we could be picking up, we could be acting on, and we could prevent this, and it's not an inevitable progression. So let's look at 5 important blood marker categories. First of all, we're going to look at nutrient imbalances. We're going to look at markers for cardiovascular health. We're going to look at blood sugar markers, and we're going to look at anemia markers and immune system imbalance markers. So I'm not trying to train you to be doctors, so apologies for the jargon, but I hope that I can share with you the importance of this and of getting this working, So let's look at nutrient imbalance markers first of all. And we're going to take a case of Helen. So she's a 55-year-old physiotherapist and mum. She's feeling exhausted all the time. She's tearful and anxious, and she can't focus. She's just not herself. Her bones are aching, her muscles are aching. She's getting complaints from her employees, and her mood is worse in the winter, and she only really feels well in the summer when the sun's shining. What could this be? So there's lots of different things that could be wrong, but some of the features here are classic for vitamin D deficiency. So let's look at vitamin D testing. And here we have one of the displays from the computerized blood chemistry report that I use. And here we've got, this is UK or standard international units. So this is not the units that they use in America, for those of you that are in America. But we can convert easily. So we convert while we're creating this report. So you can see this is the optimal range for vitamin D, but normal range is 74 to 249. And in actual fact, I can tell you now, as an NHS GP, the NHS considered normal to be anything above 50, which is here somewhere. So well into the red. And we know from COVID, we know from the experience of the last few years that low vitamin D is significant. It's unusual for it to go this high. Occasionally, people do have problems with overdose. And so it's important, if you are taking high doses, to get your levels checked and to only take high doses for a restricted period of time. But to think that the NHS normal range is just from there up to 200, really. So from there to there is what's considered NHS normal. Anything above there, and they start panicking. But they don't panic enough at the low level. And this is quite a thing, because I have cured many cases of fibromyalgia and chronic fatigue syndrome just by checking people's vitamin D and getting them back to optimal. Now, what can be contributing to vitamin D deficiency? It can be diet, it can be sun exposure, but it can also be genetics. So some of us with a vitamin D receptor issue have to take higher doses of vitamin D than the next person. And that's okay. But it's useful to know, and that's where my nutrigenomics package, where I look in depth at people's genetics, can help to pad out the picture, to help to get a better view of what's going on. So what are we going to do about this low vitamin D? Again, this is UK units, so much higher than US units. So do work with your primary provider if you're under anyone's care, if you're working with a doctor or physician. Vitamin D, if it's less than 20, that's really low. So I recommend 20,000 units every day for 6 weeks, then retest, or 20,000 units a day for a month, that's 4 weeks, and then 10,000 units for 2 months and retest. But you must retest. And in addition, if you're taking these high doses, you need to check the bone profile at 1 month and a bone profile in vitamin D at 3 months, okay? Because this can upset your calcium metabolism. And it's also important to be supplementing with K2 and magnesium at the same time to keep things in balance. So I don't recommend just vitamin D on its own, even though that's often all we can do in the NHS. So, you can see that there's a different, even for somebody who's educated in functional medicine, I can't use functional medicine in the NHS system. There's just no time. Vitamin D, if your level is 20 to 50, still take 10,000 units a day for 3 months and retest. If you ask your GP and you get a level like this, you'll be told 20,000 units, 2 tablets a month, no, 2 tablets a week. And I prescribe more higher doses than most, but I give 40,000 units a week for 6 weeks or for 8 weeks, and then 20,000 units a week. So much less than this. And then these are the other guidelines. So, and if you just go, what the NHS advice is, we're told to just tell the patients to go and buy a supplement, a vitamin D supplement from the chemist or health food shop. And they go and buy something that's either 400 or 800 units. Now look at this, 800 units a day compared to 10,000 units a day. It's not adequate. You need to know more about what's going on before this. So let's look at the next section, which is the methylation nutrients. Now, methylation, that sounds like a long word if you've not studied chemistry. Methylation is a process that is part of the detoxification of chemicals in the body. Now, that's not just external chemicals like poisons and chemicals, pesticides on your food. It's not just that, but it's also the hormones. Our hormones need to be metabolized and excreted and made safe, and other chemicals that our own bodies produce. So methylation is a crucial part of the process of metabolism that goes on in your cells. And the methylation nutrients that are of high importance are B6, B12, and folate. They're essential for DNA repair and methylation. They may be affected by genetics again. So this is why the genetics is important. They're present in green leafy vegetables, and the serum levels may not be an adequate marker. So what are the blood markers that we do use to assess B6? So B6, B12, and folate. Homocysteine, which is rarely measured in the allopathic medicine, but it's a really useful biomarker. We also look at mean cell volume, which is one of the measures that comes out when we do the full blood count or complete blood count. So part of the hematology markers tells us the size of the red cells, and that helps us to detect B12 and folate deficiency. MMA, which is in urine or blood, and again, not done in the NHS generally. Folate and metabolites, and serum vitamin B12, which is not accurate. You can have a high serum vitamin B12 level, which is generally the only thing we measure in the National Health Service in the UK, and you'll actually have a deficiency in the cells. So restricting B12 or worrying about too high levels is not the best plan. Low vitamin B6 markers specifically include some of these. So these top ones are grouped together. They're what we call the liver function tests. These ones are all related to the full blood count, which is our hematology test. Iron is something we look at as part of, in some cases, as part of this assessment, and RDW is again part of the hematology. Low vitamin B2 or thiamine markers. Now, B2 deficiency is very common with alcoholism. So it's something that alcoholics tend to have very poor diet, but they also seem to have a B2 deficiency through absorption as well. So we can pick up these using fasting glucose or some of these hematological readings and the LDH, which is another marker. But fasting glucose, hemoglobin in hematocrit, we certainly do in National Health Service general practice and allopathic medicine, but we don't interpret it in this way. I'm not thinking in terms of B2 when I've got my 10-minute appointment, I can tell you. Vitamin C. We all know about vitamin C. We all have learned at school about scurvy in the sailors until they were given fresh oranges. What are the markers of vitamin C? Well, alkaline phosphatase, that's one of the liver tests. These are all hematology tests, so part of the full blood count. And these ones also are part of the full blood count. So these, again, we measure these, all of these, on a routine basis. But in my allopathic practice, where I'm having to work in the NHS, which I'm planning to leave, by the way, we don't have time to start looking for vitamin C deficiency. We don't interpret it in this way. So let's look at the next case study. So this is Emma. She's a 53-year-old accountant, and she's noticed increasing headaches. She's now getting migraines nearly every week. It wasn't a problem until the last few years. And she's now finding it really difficult to concentrate. She feels unsafe with major decisions. She's working later and later just to make sure she's doing things right. And ultimately, she has to take time off work. Does that sound familiar? Headaches and migraines are so common in the perimenopause, but often there's a very easy fix. It can be due to poor hydration, so not drinking enough good quality water. I'm not talking about tap water here. But it can be due to mineral deficiencies. And we very commonly see, as functional medicine doctors, headaches caused by zinc or particularly magnesium deficiency. And these trace minerals, they're only needed in tiny amounts, but they are essential for the way your body works, the way your cells produce energy, the way your cells work in conjunction with each other, and the way your organs synergize together. So zinc, we may recognize a low zinc because of low alkaline phosphatase. That's that liver marker again, and low white blood cells from the full blood count. Molybdenum can be recognized by high serum iron and low uric acid. We only measure uric acid in allopathic medicine if we're looking for gout. So if somebody comes in with short, sharp joint pains, we'd be measuring uric acid. Isn't it interesting? Selenium could be recognized by a low free T3, but in NHS medicine, we're not allowed to request free T3. We only measure the TSH. I'll come to that later. And copper deficiency could be recognized by these. Let's look at Sally. So Sally is a 59-year-old lawyer. She's noticed heartburn for the last 2 years. This is increasingly frequent, and it's actually keeping her awake at night. She went to the chemist and talked to the chemist about it, and the chemist gave her some Rennies first of all, and that helped a little bit. She went back and she got some omeprazole that you can now buy from the chemist. So the chemist can sell you omeprazole. She then went to the GP and said, look, this really helped me with my symptom. And the GP prescribed omeprazole. She's still on it a year later. Now, what's the problem with that? We've got rid of her symptom. That's all we need to do, surely. Well, maybe not. Low stomach acid is something which is very common, especially as we get older. As we get older, we produce less stomach acid. Surprisingly, low stomach acid actually gives us the symptom of heartburn. This is because when you think of the diaphragm, which is just below the rib cage here, the diaphragm is a muscle, and it has an opening through which your esophagus, your gullet goes. And that opening is kept tight by this sphincter here. Now, if you have low stomach acid, this muscle relaxes, allowing some acid to come up into the gullet and cause heartburn. So in actual fact, this case of heartburn is not caused by high stomach acid that needs to be quashed by omeprazole. It's actually caused by low stomach acid, which will be made worse by omeprazole. Is that a problem? What's the problem with having low stomach acid? Well, In actual fact, we get low protein and albumin levels and then you get muscle deterioration and much more because you can't absorb your food properly without your stomach acid. You get low calcium levels, you get low magnesium because you're not able to absorb the nutrients in your food properly without that stomach acid. So these are some of the markers that we use that can be used to predict low stomach acid. Urea can be high or low. These are part of the standard biochemistry test that you will get. Uric acid is the gout one. Ferritin we tend to only check it if we're thinking about anemia. Iron and hemoglobin. So hemoglobin is a standard one from the hematology, from your full blood count. And then these are from the full blood count. But try as I might, even as a functional medicine doctor with all that I know, I can't keep this information in my head. Isn't that surprising? So I need a little bit of help from some technology. Let's look at pancreas inflammation. So pancreas inflammation can occur because of pancreatitis, where the pancreas is really inflamed, and you can result in poor digestive enzymes, or you can have poor levels of digestive enzymes anyway. Again, if we're not releasing enough enzymes from the pancreas into the small intestine here, then that can impact our food absorption and nutrient absorption. And again, we end up with low albumin and protein. And we can also pick up levels of this if the amylase is high. And these are some of the other biochemical markers that we use for this. So let's look at cardiovascular markers. One of the reasons you're here, because heart disease is if not the leading cause of death. We want to be able to do what we can to prevent that. So these are the routine cardiovascular markers. We get these done regularly in the National Health Service. We want the total cholesterol to be low, the triglycerides to be low. We want the HDL or high density lipoprotein to be high because that's a protective one, and the LDL to be low. So, but in actual fact, when you start to look in more depth, it's a bit more complicated than that. Of course it is. Anything is simplified at several levels, isn't it? But if you want to look more closely at the cardiovascular markers and pick up things before there's a problem, we want to look at oxidized LDL, not the total LDL, because it's the oxidized LDL that's the problem. We want to look at fibrinogen. If possible, we want the calcium CT score, which is a relatively newcomer, which helps us to predict cardiovascular disease. And we want the homocysteine, the very low density lipoprotein. So what's a lipoprotein? A lipoprotein is a compound that's got partly lipid and partly protein. So it's a lipid and protein joined together, lipoprotein. And within the cardiovascular system, these lipoproteins carry cholesterol around in the body to supply it to where it's needed. Is cholesterol needed? Well, yes, it's actually the building block for all of our sex hormones and for a lot of other compounds that are needed in the body as well. So the cardiologist's plan to get your cholesterol as low as possible can actually contribute to depression and to hormone imbalance. That might be a light bulb moment to you, especially if you're in perimenopause or suffering from PMS or polycystic ovary syndrome, or postmenopause and having lots of symptoms of hormone imbalance. So this is an advanced lipid profile. And once we go into an advanced lipid profile, we look in even more depth. So here we're looking at subclasses of high density lipoprotein. We're looking at lipoprotein little a and apolipoprotein B. All of these sound very, very complicated, and I completely agree. They are very complicated, but they all help to shed light on your risk of cardiovascular disease and what to do to reverse that. In addition, your genetics are involved in your risk of cardiovascular disease. So again, knowing your nutrigenomics, having a nutrigenomics session with me will help you to know where your genes are, know what to do to reverse that impact. So on to my mum again. Let's talk about diabetes, shall we? As it's something close to my heart, as you may have gathered. So let's look at the blood sugar markers. So ideally, we want fasting blood sugar to be 75 to 85 if you're in the US, 3.6 to 4.9 if you're elsewhere. We want the HbA1c to be less than 31, and we want your triglycerides to be low. And we want to know your C peptide, insulin. I wouldn't worry too much about fructosamine. It's shorter. It provides a shorter amount than the HbA1c. And we don't tend to look at antibodies. No, please, Guy. No. So let's look at the functional lab ranges here. So the minimum and the maximum, I've shown you this before. Now let's explain what HbA1c is. I told you that I'd explain about that. So hemoglobin A1c is an indirect measure of blood sugar. It looks at your blood sugar over the last 120 days, 90 to 120 days. We call it 3 months. And this is because glucose gets attached to hemoglobin on the red blood cell irreversibly. It can't come off again. It's stuck. And so because the life cycle of each red blood cell is 90 to 120 days, that's why we use this as a marker for how much blood sugar has been circulating, how much sugar has been circulating in your blood, and therefore your risks. Okay. Glycosylation is irreversible. But I want to point out here, it's not just the red blood cells that have got this glycosylation happening. If it's happening to your red blood cells, it's happening to the nerves in your legs. It's happening to your retinal nerves. It's happening to your retinal blood vessels. It's causing diabetic retinopathy. It's causing kidney problems. It's attaching to kidneys. The science is there. The glycosylation is happening at this level. If it's happening to your red blood cells, it's happening elsewhere, and it's irreversible. So that's why it's important to pick up what's going on with your blood sugar early. And this is where things like the Freestyle Libre continuous blood glucose monitoring can give us such insights into what's going on, what contributes to high blood sugars, like sleep deprivation and stress and exercise impact. And it's invaluable. So what are the negative effects of insulin resistance? It get increased body fat, especially around the middle. So a lot of women like me get a little bit of a midriff in our 40s and 50s, and a lot of it is related to a lot of these systems start to go awry in our 40s and 50s. Damage to blood vessel linings, elevated inflammatory markers, hypertension. So what does damage to blood vessel linings mean? That means the endothelium lining the blood vessels is getting damaged. That increases the risk of cardiovascular disease that we've talked about, so strokes and heart attacks and peripheral vascular disease and dementia. But it also increases the damage to the blood vessel linings in the microcirculation. So, for example, the blood vessels that supply the nerves in the legs, hence diabetic neuropathy, where you get numbness and then pain in your feet. Elevated inflammatory markers. Well, if your inflammatory markers are raised, that means there's inflammation going on throughout the body because the blood is going throughout the body, and that is damaging tissues. Hypertension or high blood pressure, increased growth hormone and thyroid hormone, decreased growth hormone and thyroid hormone. So if we have decreased thyroid hormone, again, common in our 40s and 50s, especially as women, me as well. Decreased growth hormone. This is really important because growth hormone needs to increase overnight when we're starving so that we can build up muscle. And that's why it's so important to avoid eating within 3 hours of going to bed. And then ultimately, this insulin resistance can lead to diabetes, dementia, heart disease, peripheral vascular disease, retinopathy, the commonest cause of blindness, kidney failure, the commonest cause of kidney transplant and dialysis, birth defects if you're young enough to get pregnant, and much more. So we've also got ideal postprandial or after meal glucose test results. And again, this is where a continuous glucose monitor can be so good because you're not having to prick your finger all the time to check this. But if you really want to know what's going on with your blood sugar and you are using a finger prick monitor, you need to do it 15, 30, 45, 1 hour, 1 hour and a quarter, 1 hour and a half, 1 hour and 3/4, 2 hours, 2.5 hours, all of that after a meal and after any new food challenge to see what different foods are doing to your body. So it's not just a case of measuring it once, 2 hours after meals, which is what we tend to do in allopathic medicine. So I'd like to share with you how I can help you with this computerized report that allows me, it gives me superpowers, frankly, in being able to spot what's going on in the body. It's amazing. And I'm going to share with you mine in a minute. So what's different about this? The functional approach to a biochemistry screen and full blood count analysis, which are the two of the things that we've been talking about, it's around changes in physiology and not pathology. So we're using ranges that are based on optimal physiology, not the normal population. And we've got this tighter physiological range. We're not looking for disease, we're looking for pre-disease, and this allows us to evaluate the area within the normal range that we can see what's not quite right in the systems associated with that particular biomarker. So we can detect patients with changes in your function before it becomes disease. We can also identify the factors that stop you from achieving optimal functioning in your body. So this is one of the pages of the report, and you can see here the green is the optimal range, the amber is outside the optimal range but within the normal range very often, and then the red is way off and we need to do something rapidly about that. And when I get your blood results, if you decide to go with this computerized analysis, I then spend time putting your blood test into our system. I convert that to standard international if I need to. We can put whether you're fasting or non-fasting, whether you're male or female, and I put your test date in and also your name. And then from that, then I put the individual marker readings into the lab test, into the chart. And there's space here for me to put individual messages, like, for example, one that I did last week, the calprotectin isn't included in the blood chemistry, so I commented on the calprotectin being normal. Another one had also a result for their fecal occult blood, which is hidden blood in the stool, and I commented on that being normal. Another one, I commented on their ECG. So there's space there for me to put other notes. And then we get ranges. So I'm just going to move from here for the moment. And I'm going to go to, oh, it's run away. Okay, so I'm going to stop my share for a moment until I find the report that I want. Okay. Okay. Ah, let's look at this one. Okay. So this is one of my reports, so no patients were harmed in the making of this video. And as you can see, at the time of this report, I was a 56-year-old female, but 51 years old at the time of the test was taken. We've got the collection date, so I add that when I'm adding the blood results. And then when you get this report, you get a little bit of information. This is actually the practitioner report, so it's a more complex version than the patient version, but it explains to you what's inside. So here's the sort of key, and these are hyperlinked. So there's a section of my notes that I was talking about just now. There's a little bit about the blood test results and about functional medicine and why we have functional reports. So what's inside, and health concerns and appendix. So this is the introduction. So this explains about functional blood chemistry analysis, what it involves and what the functional approach involves, as I've said. And you get this to peruse at your leisure. You get to download it. You can print it off if you want, or you may just want the video of me going through it with you, because that's all part of the program, the package that I have. So then we talk a little bit about that. And then the blood test results are, I like this color coded. It just helps me so much. I prefer the traffic light system rather than the blues. I love the blues. They're so beautiful, but they make it more difficult to see what's abnormal. This is simple. Okay, so if we were to look at my blood glucose to start with, okay, so my my fasting glucose is optimal. My HbA1c, look, is just above optimal, 5.3. So it's at the top end of the optimal range. So it's not something for me to be worried about because of all the lifestyle factors that I implement, the way I live my life, the exercise, the sleep, the stress management, and the nutrients, the vitamins and minerals that I take every single day. Otherwise, this would be above optimal. I have looked at my genetics. Of course I have. I've got something like I think it's like a 38% chance of developing diabetes. So I'm going to look after this side of things for me. This is the estimated average glucose, which is just above optimal, only by 0.02 points. And then the triglyceride to glucose index is optimal as well. So wherever there's a green square like this, you can just click on that and it will take you to a more in-depth explanation. And then you can click back to go back to where you were. And when I go through this, I give you a report where we're just focused on your three main concerns, or unless there's something that really flags up that is urgent and we really need to work on, and it's not amongst your three main concerns. So I keep things simple, but I do explain this report in depth. So here's the kidney function. The urea is above optimal. The creatinine is below optimal. And the ratio of urea to creatinine is high. So again, if you look here, you can just find out a little bit more about that. It's just an increased level is associated with kidney dysfunction. And then click back there to go back. So for each of these kidney function, you can just click on that. So the urea and creatinine are part of protein metabolism, and if they're raised in the kidneys, it means the kidneys aren't filtering them out as well as they should be. With the electrolytes, I've got a slightly low sodium at this time, but my potassium and chloride and this ratio are all normal. My uric acid is slightly above optimal. That's interesting. Uric acid, when it's way high, is a sign that can be related to gout, but there are other systems that are involved in other things as well. So levels can be increased due to overproduction by the body or decreased excretion by the kidneys. Increased uric acid levels are associated with cardiovascular disease again, and oxidative stress and kidney dysfunction and intestinal permeability, so dysbiosis. Intestinal permeability syndrome, which is another talk altogether. And I just love the insights this gives me that help me to really put together an approach to help your action plan for you to put in place to improve these markers. So here's calcium and phosphorus. They're slightly higher than normal. And the liver, this is the liver function. My alkaline phosphatase is slightly high, so we want it less than 100. So it's 106. And again, you click on that and you can see that what causes that elevated levels can occur with any liver dysfunction, especially sensitive to obstruction in the biliary tract. And the degree is in direct correlation to the severity of the obstruction. But it can also, what's useful there, it always goes to the top of the page, is elevated levels can be with normal bone growth in children and with healing fractures. We also see it in things like Paget's disease of the bone. So these liver function tests are normal. LDH is high. So it's a group of enzymes that are involved in carbohydrate metabolism, and increased levels can evaluate the presence of tissue damage in the cell. And it's found in many tissues of the body. So it's not very specific. Can be due to damage in heart, liver, kidney, skeletal muscle, brain, red blood cells, etc. So then we go on to, so that was the LDH. These are the other markers. So bilirubin, which tends to be high in Gilbert syndrome, which is an inherited disorder. And also if you've got gallstones. And you've got direct and indirect bilirubin. So the total direct and indirect. So looking at the direct one. So an increase in direct bilirubin can be associated with blockage in the liver, gallbladder, or biliary tree. Sounds like I need to do another liver flush, doesn't it? And then the iron markers, not bad. And then cholesterol. So my cholesterol's not bad. The LDL is a little bit above ideal. HDL is good within the optimal range. That's the good cholesterol, remember. Yeah. So, and then onto the thyroid. So you can see a big triangle here. This is right in the red. So the TSH was 0.08. Now I have an underactive thyroid, which produces a high TSH. So this indicates that I was being over-treated with my thyroid hormone at the time of this test. Now, interestingly, if this is low, you would expect the thyroid hormones to be high. The total T4 is within the optimal range, but the T3 is low. This is a classic example of what's not generally picked up in allopathic medicine. There's obviously an issue with conversion from T4 to T3. So T4 is converted to T3 in the body, in the peripheral tissues. Most of the hormone produced by the thyroid gland itself is T4, and all of the hormone replaced in allopathic medicine is T4. And so we need to work on T4 to T3 conversion. So I need to optimize my supplementation, make sure I'm having enough zinc and selenium, and do some other habits that will help, and be totally gluten-free, which I am, but there's some work there to be done. And then my antibodies, optimal there, the thyroid peroxidase antibodies. These are measures of inflammation. They're okay. Vitamin D is below optimal, as I showed on the previous slide on vitamin D. So even though 74 is well above the optimal range in the NHS, we actually need it to be higher if we want optimal health. And then here's my full blood count. So this looks at the mean cell volume that we were talking about. That's slightly high. So it does suggest I've got a bit of a folate or B12 deficiency. The white blood cells, monocytes are slightly raised. So again, let's look at the green thing. So that can be a sign of infection. They are phagocytic cells, the monocytes, that move out of the blood circulation and into an area of infection or inflammation. They can stay risen in the recovery phase of infection. So I may have recently had an infection at the time of this test. My neutrophils and lymphocytes are normal, suggesting that I don't have an acute viral or bacterial infection at this time. Yeah, so that's that way of looking at it. And I find that way the easiest way of looking at the actual values. But just in case you prefer a different way of looking at it, we have a comparative with just the figures here compared to the optimal and standard range. So you can see it from the colors again, which things need the highest level of attention. And then the next section looks at the blood test score. So it's another way of portraying the same data. So you can see which things are most abnormal. And then history. So here we've got my 2016 compared to my 2018 results. And so that's really useful when I'm working with a client over a period of time. So in my VIP packages, for example, in my 3, 6, and 12 months packages, I'll be doing this report at the beginning, middle, and end of those packages, preferably every 3 months. And that really helps us to see how our interventions are helping. And then this is looking at the things that are out of optimal range. So this again is where our little squares were going to when we were looking at the last section. So I'll skip past those. And then we have further explanation of the blood markers, looking at different ways of looking at it, because as I said, this computer system is bringing these results together. So you saw from my slides that there are different markers from all sort of different blood tests that may signify, say, a B6 deficiency. But this part brings it all together. So first of all, we have the functional body systems. So this looks at the level of dysfunction in various physiological systems in the body, and it's flagged up my thyroid function as being the highest risk, the kidney function needing some attention, the GI function, adrenals, and gallbladder. So we're generally looking at anything that's 50% or above risk or probability of dysfunction. We would focus on here. So this report helps me and you to know where we need to focus our attention, how we need to focus our action plan. You can see how brilliant this is for helping us to pay attention to the right areas. And then if we look at this one, for example, the thyroid function, what this is showing is a lot more information about the thyroid and about what could be going wrong, but also about what extra tests would be useful in working out what's going on and in supporting this. So reverse T3, which is time for another story, reverse T3, T3 uptake, free thyroxine index and free T3 and reverse T3 would be, free T3 to reverse T3 ratio would all be useful additions to this test. Likewise with the kidney function, with a 78% risk of dysfunction. Additional measures would be the magnesium. Don't know why they've said GFR in African American, but there we go. So that's that one. And then if we go on to the next one, this is looking at accessory systems. So additional physiological systems that are not related to individual organs or body systems. So in this case, we can see that there's an issue with inflammation. So we need to pay some attention to that. So we're looking at how we're going to look into that in more detail. Highly sensitive at CRP would be useful. Fibrinogen, homocysteine, as I've said, that's really useful for cardiovascular disease. And myeloperoxidase, ferritin, and creatine kinase would also be useful in working out what's going on to a greater extent. Nutrient status is the next chart, and that's showing electrolyte status and vitamin status, particularly over 50% risk. So this is, again, an algorithmic analysis of the blood test. So we've got electrolyte status and vitamin status. And with the electrolyte status, it was the sodium being reduced, and they've suggested a serum magnesium would add to the picture. With the general vitamins, it was also suggested that homocysteine and MMA and folate and B12, especially red blood cell folate, which is more accurate than serum folate, would be helpful in elucidating what's going on. The next section of this report is individual nutrient deficiencies. These scores represent the degree of deficiency for individual nutrients based on the blood results. So we haven't got as much detail as somebody who's got these levels as well, but we can see that I've got a high level of vitamin D need, despite my levels being within what the NHS would say is optimal range. Here you go. So it's worth, so there's nothing else needed to detect that. The B12 and folate, this again was showing that they would recommend us get an MMA level and homocysteine. And then the calcium need, that's because of the phosphorus being high and the vitamin D being low. So it would also be worth getting a calcium level. Yeah. So the next section is the clinical dysfunction. So this shows a list of likely health concerns that you may be suffering from based on an analysis of the chemistry screen and complete blood chemistry result. Here we've got thyroid conversion syndrome may be an issue, intestinal hypermobility. Now this is the practitioner report, I have to say. The patient report doesn't have this, but look how helpful it is in helping me to focus my work with you down to the finest level. So we know that we need to work with this patient, i.e. me, on intestinal permeability, on thyroid conversion syndrome, on anterior pituitary dysfunction because of that very low TSH, and renal insufficiency. So let's look at what the thyroid conversion syndrome says. So consider running the reverse T3. I think that would be very useful in this patient. Intestinal hyperpermeability. Well, I would know that in that situation, I'd want additional tests that aren't included here because this is really only focusing on biochemistry. And then adrenal insufficiency. Yeah, I did have adrenal fatigue, particularly in 2016. I burnt out as a doctor. I didn't even know adrenal fatigue as we sometimes call it, but it's not accurate. But adrenal insufficiency was even a thing. So we need more levels like cortisol. And basically this would lead me to do a Dutch test, which is another masterclass. Yes, so gastric inflammation. So you can see how helpful this is for your practitioner, and you can ask for a copy of this version of the report as well. And then in section 4, health concerns. So here we're looking at health concerns that looks at the areas that need most support. In this case, vitamin D and thyroid conversion, GI permeability, anterior pituitary, B12 and folate, kidney, adrenal, and digestive. And this is me as a healthy person. So, you know, this can be so useful. And that section 5 is the appendix. So let's go back to PowerPoint. Yes, great. So you've seen this in much more detail than this PowerPoint shows, so I can click through a lot of these. So you've seen how beneficial it is to look at results over time. And to look at the probability of dysfunction, to look at the nutrient status, to look at the functional body systems. So blood testing is no longer just a part of disease or injury management. It's a vital component of a comprehensive functional medicine workup. It has a vital role to play in uncovering these hidden health trends and comprehensive and help us with health promotion and disease prevention. So, having seen all that, would you like to know how to get this report run on your blood? And what's more important, maybe, although the explanations are very, very good, would you like to know what to do about it? So I now have a blood chemistry review consultation and computerized report package, and that's what I'm going to present to you. So what's included in this is, first of all, you will get your blood tests done. So you may already have some done with your own physician. The cost of the blood test is not included in the package, but I do have access to blood tests in different countries that you can get done. Then I will put that into that blood chemistry report. So that will take up a lot of my time. And that gives you a detailed functional analysis of your existing blood test, identifying those organ and hormone dysfunctions and nutrient imbalances, and follow-up testing recommendations. We will also have a 90-minute lab review and strategy session. So I will already have looked through your report, looked at what we need to focus on. I will have spent a couple of hours on this already. And then I'll have a 90-minute lab review and strategy session with you, where you'll discuss your health history. We'll get you to fill in questionnaires just beforehand so that we've got a lot of information, and we'll get your questions answered, and you'll get more tailored one-to-one direction based on the results of your lab test in conjunction with your symptom questionnaire. You'll also get a food and supplement plan for addressing the imbalances identified, and I'll give you guidance on the most appropriate next steps for you, including any additional lab tests indicated, although the lab tests are not included in the price of the program. So that's a total value of £1,000, although in terms of the benefits to you, I think the value is much greater than that. So have a think for the moment. What do your health issues cost you at the moment? If you're wondering if you can afford to do this now, and I understand we're in a credit crunch, we're in a situation where everything is pushed, but I'd like to suggest you think about what it's really costing you to not feel well, and what it will cost you in the future to get these illnesses that could have been prevented, and not having this kind of guidance and support in place. It will cost you doctor visits in terms of time and maybe money, supplements, medications, and other treatments, loss of career opportunities, or if you run your own business, reduced number of clients that you can see in a day, loss of confidence and productivity, relationship discord, and often it impacts your ability to have fun. Many of my clients, when we have our entry discussion, they talk about how they can't go out and do their hobbies anymore. They don't have the energy to do the things that they want to, or they're in chronic pain, which is so unnecessary. The total cost of this is hundreds of thousands of pounds and years of your life. So what's it costing you not to invest? If the investment is $900, £900 rather. And if you've been doing the multiple practitioners syndrome and you've been seeing lots of different practitioners and you've still not got the answers, and you've been doing loads of research, I mean, maybe you've not been seeing other practitioners, chiropractors, herbalists, and nutritional therapists, but maybe you've been spending a lot of time doing research and trying to make head or tail of the different advice that's available on the internet. That's taking you a lot of time. And I want you to recognize that your time is valuable because your time is irreplaceable. If you've been on supplements and medications and other treatments, that's costing you a lot. Since, except for most of the medications, it's not covered by insurance or the health system. So how many hundreds of pounds worth of stuff do you have sitting in your cabinet, supplements, etc.? And what about the loss of your career? People don't think about that, but if you're in a job or running your own business, even more so, and you're feeling brain fogged, you're not going to get the promotions that you know you could because you don't have the clarity to be able to get there. And you don't have the self-confidence to apply and to stand in your power. And when you're running your own business, well, we know where that leads, that you're not able to have the client conversations that will convert. If you're somebody who needs to get up in front of people and you're embarrassed about your body, you're losing opportunities that could be making you lots. If you're getting hot flashes, that could be embarrassing you and making it more difficult to do these talks. And these are big costs that nobody takes into account. What about relationships? Is your lack of health costing you pleasure in relationships with your partner, your kids, or your friends or family? And then what is your health costing you in terms of lack of fun in your life? If I could do a program that promised me more fun in my life because of better health, then I would sign up in an instant. People are spending a lot of money for fun, like going to sports matches or on holidays that may cost thousands of pounds. But what would you be willing to pay to get back all the lost years of pleasure that you've missed out on due to your health? So as a result of this blood chemistry review, you will be able to identify imbalances before they become diseases. You'll be able to identify nutritional deficiencies and toxic excesses. You'll be able to notice immune system imbalances and prevent illness. You could identify potential digestive imbalances and see where further testing is needed or where you need to adjust your diet. You can identify inflammation and correct it before it becomes serious. There are lots of ways to correct it, including getting your omega-3 to omega-6 intake right. That's your fatty acid intake. You can identify causes of low energy. I've shown you that time and again today. And you can have a roadmap of what your next best steps should be. So what's included again is that there's a computerized blood chemistry report that gives you a detailed functional analysis of your blood test, identifying potential organ and hormone dysfunctions, nutrient imbalances, and follow-up testing recommendations. Plus a couple of hours of my time putting that in and considering the report. And my time is £360 an hour. So there you go. A 90-minute lab review or strategy session with me at the moment, and to get your questions answered and receive more tailored one-to-one direction. A food and supplement plan for addressing imbalances, guidance on the most appropriate next steps, including any additional lab testing that is needed. Total value of £1,000. And that usually costs £750. But for you, for a short time only, I've got a special offer of £597 for this package. If you use the code BCA153, that stands for blood chemistry analysis, in case you wondered, BCA153, and you go to the website drali.com/lab review, drali.com/lab review, and that's how you will get this special offer. Now, I'd like to circle back, and I know time's come on. We've only got 6 minutes left in of our hour and a half, and you've been so patient. And really, I have made it shorter, but I've focused more on cases and on my case as well. But let's have a little bit more of the technology, and I'll skip through the irrelevant bits. But let's talk about Shelley. So she's a 46-year-old HR director. She's increasingly tired week on week. She has heavy, unpredictable periods. Sometimes she can be bleeding for weeks and weeks. She wakes unrefreshed. She starts making mistakes at work. She's so tired, and she's feeling more and more desperate and despondent. She tries to hide her symptoms, but she feels she can't go on. What could be wrong with her? Well, it could actually be anemia, couldn't it? Especially with those heavy periods. So what are some of the symptoms of anemia? Fatigue, weakness, headache, shortness of breath after exercise, chest pain, pounding in the ears, brittle nails, pallor, palpitations, dizziness, cold hands and feet, to name but a few. Other things could be yellowing of the skin, but also cuts at the side of the mouth. Sometimes that's due to thrush, but sometimes that's just due to anemia. So there are several different types of anemia. There's iron deficiency, which is a microcytic type. It has small red blood cells. There's folate and B12 deficiency. So those are two different types of anemia. They tend to be macrocytic or have large red cells. There's vitamin B6 deficiency, which can cause anemia. Hemolytic anemia, where the blood cells burst or lyse. So hemolytic, the red blood cells have lyse, have broken open. There's aplastic anemia, which is when the cells aren't made in the first place. So there's something wrong with the bone marrow. And there's sickle cell and thalassemia, which are genetic anemia. So this is sickle cell anemia with sickle-shaped red blood cells. It provides protection against malaria, which is why it is still a problem. And then anemia of chronic disease, which is very, very common because in health, we see so many people with multiple chronic diseases these days. So the most important anemia blood markers, basically we want to look particularly at the full blood count. Now, the full blood count, as I've shown you when I went through my own result, has loads of elements to it. Different measures of the red blood cells, the red blood cell count, the hemoglobin, the hematocrit, the immune cell volume, the red cell distribution width, which is a reflection on whether the body is making new red blood cells, because new red blood cells are, baby red blood cells are larger in size and they've still got a nucleus. So looking at this variation can tell us whether there has been an anemia, even if there aren't other signs. So some of the other blood markers for iron deficiency specifically are iron, ferritin, transferrin, and there are other tests that we can look at iron deficiency with. Now, what are some causes of anemia? These are just a few. So pregnancy, because you're spending so much energy giving to the baby. Worms and parasites, because they cause some bleeding. Autoimmune disease, heart disease, chronic infection. My mum actually developed angina because of severe anemia from a GI bleed. So it's interesting, the link between heart disease and anemia. Medication, so not just anti-inflammatories, but there's a lot of medications that can cause a low-grade GI bleed, like my mum's, and cause a gradual anemia, or they can cause a sudden bleed. They can cause a catastrophic fatal bleed, anti-inflammatories. Also, antidepressants can cause this. Prednisolone, so that steroid tablet, that can cause a GI bleed. Kidney disease causes anemia, serious illnesses and cancer, and then insufficient dietary iron, folate, B12, malabsorption, so you're not absorbing the vitamins that you're taking in, essential fatty acid deficiency, back to that omega-3 and 6 fatty acid levels, low stomach acid that we were talking about earlier, heavy menstrual bleeding, as in our case study, and internal bleeding. Also, piles can give you bleeding sufficient to give you anemia. So when the numbers are off, so these are when things are not as expected. So if someone's got high iron, you'd sort of expect them to have a high ferritin. And if someone's got a low iron, you'd sort of expect them to have a low ferritin. So these are just some interesting cases that I wouldn't be able to remember to pick up, but the computer system can. And then some of the signs that we see with the B12 and folate deficiency anemia, but the main thing to notice is the immune cell volume. So anemia is serious illness. So it's a similar pattern to iron deficiency. So often we'll find that people don't have a low iron, but they've still got this anemia for years, for decades even. And you may find that the transferrin may be normal or increased, and it's sort of the symptoms we talked about. But causes of that anemia includes any chronic disease, particularly kidney failure. We see it with heart failure, internal bleeding, hemolytic anemia, all these things. But this needs to be evaluated by a medical practitioner, okay? And now let's go on to the immune system, and then we're nearly finished. So full blood count and the full blood count with differentials is what gives us that information about the immune system, looking at the neutrophils, which are raised in bacterial infection, the lymphocytes that are raised in viral infection, or maybe reduced in viral infection, monocytes in that recovery stage and chronic infection. So remember, my monocytes were high. basophils, eosinophils, which are raised in parasites and with asthma, for example. Let's look at my dad. So my dad had a bilateral total knee replacement. He was a stoical farmer. He was fit, you know. He had both his knees done at the same time. Can you imagine rehabilitating from a bilateral knee replacement? But he was stoical. He made sure he did all the physio, and he was driving way before he should have been. But his knee replacements were fine for 18 years. 18 years. Then somehow or other he got a bacterial infection. It was actually an E. coli that was present in a urine infection he had. So we don't know how it got into his knee, but it did. And these bacteria are really clever. So any orthopedic surgeon will be very averse to doing anything, going anywhere near a knee replacement surgery or any replacement surgery when there's any infection in the body, because if you get an infection in a joint replacement, it is catastrophic. You have to take the knee replacement out. You have to go without the knee replacement for weeks and weeks and weeks while you're trying to get rid of the infection. It's a nightmare. So the bacteria sit on the metal of the knee replacement, and then they cover themselves up with this lovely thing called a biofilm, which means antibiotics can't get to it. There's nothing you can do. They are so clever. They can't be got at. You can't get rid of this bacterial infection. And he was on antibiotics for over a year. And then they decided to try this two-stage operation to remove this infected knee replacement. So the infection started before COVID. They did the first stage of this two-stage complex knee operation where you take out the knee replacement. He's not allowed to walk on it. He's got muscle flaps, skin flaps. And then December 2020, I don't know if you remember, but we had another surge of that pandemic-y thing. And he couldn't have the other operation. He still had infection in the joint. He was still on antibiotics. We couldn't go and see him. He was in a nursing home because he was unable to walk. And this, for a farmer, he was devastated. And in the end, he died in July 2021, still before being able to get the second part of this knee replacement. Now, I'm not saying that blood tests would have helped us pick up the bacterial infection before this happened, but who knows? So bacterial infection, raised neutrophils particularly, possibly low lymphocytes. Viral infection can have raised or generally a raised lymphocyte count and a low neutrophil count. So those lymphocytes and neutrophil balance give us the answer. And then with parasites, you tend to have high eosinophils specifically, also basophils. So inflammatory markers, so let's look at other inflammation. So apart from the immune system, the inflammatory markers are related to the immune system too. CRP is increased when there's inflammation in the body, and ESR also. And then homocysteine is a useful measure as well. Now let's briefly touch on thyroid. Ooh, goodness. So with the thyroid, let's look at this person. Yay, hello, it's a mirror. So this is me. I was diagnosed with autoimmune hypothyroidism in 2016. Thanks, Mum. She gave me that as well. And I noticed that I was getting sluggish and tired. I was finding it really difficult to stay focused at work. And I handed in my notice at my job as a GP. And I decided to have some blood tests done at my own practice before I left, just because it's convenient. And then my friend, who was a salaried doctor there, now a partner there, rang me up and said, I think we know why you're feeling a bit under the weather. My hair was dry and frizzy, much drier and frizzier than in this picture, which was done once I was on treatment. Hair loss, hair coming out every time you wash it, eyebrows, particularly the outer third of the eyebrows, eyelashes were falling out, weight gain, feeling the cold, Raynaud syndrome. So I had red and then white fingers in the cold, and more. So you tend to get constipation, you tend to may get heavy periods, all sorts of things. And depression, low mood, brain fog. These can all be symptoms of an underactive thyroid. So, yes, what can I say about thyroid treatment in the NHS? In common with other medical systems, the allopathic medical systems really only measure the thyroid stimulating hormone. That's the only thing they measure because they're saving money and because most doctors don't know what to do with more in-depth tests. If this one is abnormal, they may well look at the total T4. But that's all they will do. They may look at the free T4 rather than the total, actually. So they'll look at the free T4 if the TSH is awry, but they won't measure these other things. And these other things tell you everything. So as we were looking at my thyroid results earlier, you could see that the total T3 was what told us that I had a very low T3 despite normal T4, and therefore that there was a problem with my T4 to T3 conversion going on. Oops. In addition, in the allopathic system, I can measure the TPO antibodies, but not the thyroglobulin antibodies. But most doctors don't measure them because in the allopathic system, we don't do anything with the antibodies anyway. We don't know what to do about them. In actual fact, there's a load you can do. If you work with a functional medicine doctor like myself, you can reduce those antibodies using lifestyle changes and supplementation and gluten-free. But that's just the start of it. Investigating the gut for leaky gut. All these things can help to sort this out. And then reverse T3, which I've mentioned a few times today, but haven't explained. It's the mirror opposite of T3. And whereas T3 is the most active hormone, thyroid hormone in the body, the reverse T3 has virtually no activity at all. The body releases more of it when there's a reason for you to be in recovery. So maybe when you have chronic fatigue syndrome, maybe if you've got glandular fever, the body produces more reverse T3 to slow you down. It's trying to say, look, slow down. You've got to rehabilitate. You've got to get better first before you start getting on and whizzing around with your life again. So in an ideal world, we'd have all of these tests, and that's where we can get those tests in a functional medicine practice, not in an allopathic practice. So I'd like you to consider taking control of your own health and getting computerized help and my help with understanding your labs, going in depth into your functional body systems with the computerized blood chemistry report. This is such an amazing report, as I've shown you with my own today. I'm going to whiz past these because, of course, we just need the codes, don't we? So to get these results, this report and a consultation with me, what's included is my putting your blood test results into the report, doesn't include the test itself. A strategy session with me, a 90-minute lab review with me, where we will go through your symptom questionnaires and I'll give you tailored one-to-one direction, a food and supplement plan for addressing those imbalances we've identified, and guidance on the most appropriate next steps, value of £1,000. And I said how much this can change your life and your future health as well as your current health. So here is my offer to you, just for a few days, just for a few people, because I haven't got an infinite amount of time. I'm letting you have this instead of £750, which is the usual cost of this package. You'll see that on the invoice when you click on that link. With that code BCA153, you can have that special offer. So I hope you've enjoyed this. I do have a bonus for those of you interested. I have a perimenopause labs cheat sheet, which is available if you go to that website, drali.com/lab bonus, drali.com/lab bonus. It goes to a direct download. It will download your copy of this lab test cheat sheet that will help you understand your labs. But in the meantime, I strongly recommend you take advantage of this offer. So just go to drali.com/lab review, put the code where it says, do you have a promo code? Click on that. It opens up a box for you to put BCA153, and you will be able to take advantage of this amazing offer. So I hope that was helpful. I know it was. It's just enlightening, isn't it? What we can do with a little bit more information.